I'm going to give you a brief historic overview of venous stenting. Don't worry, it's not that boring. There's actually not that much. I have no disclosures. So a little bit of interesting history. The word stent is actually coined after this gentleman, Charles Thomas Stent. He was a 19th century dentist. His medical device called the medical stent device called a stent derives from the name, which he originally created these molds out of plastic called stents plastic. And in World War II was the first time this plastic with a skin graft wrapped around it was called a stent. The term stenting began in the 1920s, and that was coined by an English army surgeon. And the first time the word stent was actually used in interventional radiology was in 1983 by Dotter, who wrote stent grafting in his paper. Now, in terms of early stenting in the venous system, well, in 1986, the first coronary stent was placed. That was the first stent of all in a human. In 1986 was the first description of a venous stent in which the Gianturco expandable wire stent was used for SVC syndrome in a patient with tracheal carcinoma. 1991 was the first description of a Palmaz stent placement for central venous occlusions, and in 1992 was the introduction of the wall stent for placement in central venous occlusions. So in 1995, Berger et al. First reported stenting of what was termed the Cockett-Thomas syndrome, or we now know May-Thurner syndrome, with Palmaz stents. And in 1995, Nazarian et al. Reported use of wall stents from the common femoral vein to the IVC for a combination of post-thrombotic malignant lesions, and 2 patients of which had May-Thurner. So again, with history, there's an historic case, and I credit my partner, Nikos Labropoulos, for this one, who in 1996 was at Loyola University, where they actually did a case of a patient who presented with left lower extremity swelling and pain. Duplex demonstrated a DVT extending into the left common iliac vein, and this was confirmed by CT venogram. Patient underwent catheter-directed thrombolysis. The thrombus was lysed over a day, underwent venography and IVUS, which of course revealed a tight stenosis in the common iliac vein, May-Thurner syndrome. A stent was ultimately placed in the left common iliac. And here were pictures from that 1996 case. They actually did pullback pressures then. Here was the initial image. This is post-catheter-directed thrombectomy, where the pressure gradient is much less. After IVUS and angio, they determined that there was a compression, and they placed a wall stent. And they did IVUS post-stenting to confirm. Again, images are a little blurry. This is a 96 case. But interesting in that, this is one of the early cases. And this is what we do today. So, in 1998, the first study on using wall stent for the management of iliofemoral DVT was described with 77 patients. And then in 2000, Neglan and Raju, who we know very well with the iliofemoral literature, actually described criteria for iliofemoral venous stenting, which was presence of complete occlusion, narrowing, collateral vessels, or a preoperative pressure increase. They also demonstrated the value of IVUS in their study, saying that IVUS was superior to venogram in identifying not only the presence of stenosis, but the degree and extent of narrowing. And in their cohort, they had a primary secondary patency rates of 82 and 92%. So if we fast forward now, current data, Gagne et al. Had the most recent study with 67 patients with long follow-up, 6 years follow-up, and they demonstrated excellent primary patency of 97% in non-thrombotic patients, 75% in post-thrombotic patients. Secondary patency was even better at 188%, with significant increase in the VCSS improvement. Another large study of non-thrombotic patients showed 2-year primary patency rates of 97.9%, with a 67% improvement in their symptoms. So where is the need? Well, for the last more than 20 years, the wall stent has been used, and it's been demonstrated to be safe, effective, with acceptable long-term patency for non-thrombotic and post-thrombotic lesions. It's also flexible and mostly crush-resistant. However, there are a few shortcomings, and that's accurate deployment, which is difficult. The foreshortening can be up to 40%, and the radial strength is less at the ends. And wall apposition is very important with the wall stent. And I won't go into detail about this because I know Keith is going to give a talk, but essentially we now have some new technology that is attempting to address these shortcomings. We currently have 2 FDA-approved stents, the Boston Scientific Vici and the Bard Venovo. Under trial are the Quicksilver Vena and the Medtronic Abre stents. And you can see them here in comparison, just a range of sizes and lengths. We now have longer lengths in the stents. We have the wall stent, which we know, and now the Vici and the Venovo. But what's different now is the radial resistive force. So if we look at this paper compared all of the stents in terms of their radial force and demonstrated that the wall stent is actually pretty poor unless it is fixated at its ends. And this is where it makes difficult to deploy. If we look at the new Vici and the Venovo stents, their radial resistive force is significantly improved from the wall stent. And additionally, the chronic outward force of the Venovo and the Vici is significantly better than the wall stent, which is here in yellow. Crush resistance, the wall stent still has the best crush resistance of the FDA-approved stents. However, that is with the caveat that the wall stent has good wall apposition. So again, deployment is tricky and perfect deployment is key. So some additional improvements from the wall stent are that with the Vici stent, the foreshortening is less than the wall stent. And with the Venovo, there's minimal as well as easy deployment with the thumb wheel as we saw on the case just previously. So in conclusion, the FDA-approved Vici and Venovo stents do address the need for improved radial force and less foreshortening. The wall stent still has the best crush resistance, so consider the iliac vein compression and crossing the inguinal ligament as areas of compression. We do need long-term outcomes data for patency VCSS scores on the newer stents. However, maybe the future of venous stenting will include designating stents for certain pathologies and allow for creation of novel devices to address complex pathologies, such as bilateral disease and iliocaval disease. Thank you.